What are the health outcomes associated with different surgeries? And by benchmarking facilities, that becomes a very useful mechanism to also work on a day-by-day basis to improve efficiency. And I guess just my very last point on this would be, let's remember there are things that can be done that cost almost nothing, which have an enormous impact on health outcomes, and that is pro-health taxes. So tobacco taxation generates revenue, has a very large impact on health outcomes, and so we should always be thinking about these ways to get sort of low-hanging fruit, if you will. So I'll pause there.
Yeah, thanks very much. So it seems to me Owen is being emphasizing on the issue of investment case. Hello? Yeah, so Owen has been emphasizing on the issue of investment case. And it's talked about efficiency, which I'll come back to also from the supply side. He's been talking about efficiency from the demand side. But Edwin, let's look at the politics of investment case. Yes, you can make the case, but there are different elephants in the room, and elephant is used advisedly, not the elephant that you are thinking about. Okay, so it's politics, and I would want you to talk to us about how do we navigate the politics of financing to health.
Great. So that's a very big question, right? How do you navigate the politics in health?
Yeah.
I mean, I think there are many ways to approach it, but the first thing is to recognize the role of politics, to appreciate that financing, a big aspect of financing is priority setting and allocation of resources. And when you're setting priorities and you're allocating resources, then you make decisions that touch on people's interests. So that's really a starting point. And the reason I say this is because oftentimes, especially practitioners within the health sector, we assume that a lot of the processes and the decisions around health financing in the health sector are technocratic. And so we are naive to the politics. So appreciating that politics is real and that the decisions we are making are not just technical but also political is important. Now, once as practitioners within the health sector, as health systems professionals and so on, we appreciate that, then the second thing is to seek to understand it, and there are tools to do that. So stakeholder analysis, policy analysis, political analysis, to map out who are the stakeholders, who are the actors within the system, what are their interests, what is their level of power and their level of influence is very important. So appreciating the landscape, the political landscape with which we are operating for specific decisions. And then lastly, thinking about developing management strategies for managing these stakeholders, so political management. And part of it includes just, depending on how you map people, part of it includes keeping them informed. Part of it includes creating awareness so that they understand the implications of the decisions that are being made. But a big part of it is having inclusive, deliberative processes when you're making these decisions so that they are felt to be legitimate and they garner the political support that is required. So one, having an awareness of the issue. Two, mapping and making sure you understand the lay of the land. And then three, devising the right political management strategies to ensure that the policies that you are putting forward, the programs that you are implementing, have exist within the right political climate to move forward.
Okay, thank you very much. So, Matt, I'll be coming to you about the role that executing and monitoring should play. One, two. Yeah, Matt, I would want to talk to you briefly about the role that execution and monitoring should play in this. But before that, let me go to Prof. Irene. You have been in this system for quite a long time. You've been in service delivery, you've been in academia, you've been everywhere. And so I believe that you understand the politics of the game. Is there anything you would want to add to this in terms of how we navigate the politics of financing?
Politics is about power and process. Power is the ability to get what you want to get done. It sounds a bit theoretical, but sometimes it's good to put the theoretical in lay language. It's the ability to get to do what you want to get done. And there are resources that confer that power. Political resources. Money is a financial resource, but money can also be a political resource. Knowledge can be a political resource. So what I'm trying to say is that there's no one simple answer. I would say it's more of a deep understanding of a given issue, because the politics differs from issue to issue. And the politics also varies depending on the level you are dealing. There's politics everywhere. There's politics in your home. There's politics in your community. There's, politics at the national, at the global level. So, there's no simple answer. I would say just get a deep understanding of the issues and be able to think on your feet and alert to windows of opportunity and how to use them. That's the way I would encapsulate that answer. Thank you.
Thank you very much. There is politics in my home. The one in my home is easy because I'm not the boss. Right. So Mark, let's move to issues of execution and monitoring. In the context of whatever we have available, what role do you think execution would play, and then monitoring in terms of getting us or inching us closer to UHC and health security?
Execution, you're talking about budget execution,
Exactly.
for example. So a couple of things here. I mean, it goes without saying that good information, but with that good diagnosis of what's going on in the health system, it's basically the lifeblood of policymakers. And it's the lifeblood of policymakers to develop strategies to progress towards UHC. So a very quick example, what we see, and it'd be interesting to know if you could do this calculation in Ghana. What you see in many countries is that spending per patient, let's say, under an insurance scheme is often multiple times higher than it is for those not in an insurance scheme, right? And if you think, if that plays out over time and the insurance scheme is very dynamic and it's getting better and it's maybe spending more, and it's, the people it serves are getting more and more and getting better, but those that are outside are maybe getting a little bit left behind. It's just another example of, as a minister, taking that bigger picture, which you have to do if you're concerned about UHC, because anyway, so that's just the first point. It'd be interesting to know that type of analysis that system level analysis is critical. But on the execution point, I mean, I think, there is a case, I think, to be put, and I think we've already put it yesterday and already a little bit today, whether you have a health insurance scheme or you don't, it seems to be the case that most spending in health still runs through the budget, right? So there's a huge agenda now on continually improving how spending takes place through the budget. And there's 3 dimensions to that. Very quickly, there's budget formulation, budget execution, and budget reporting. On the budget formulation, I think the big issue there is when you look at the way many health budgets are structured, they don't always reflect the priorities laid out in Ministry of Health strategies, right? So reflecting health priorities in health budgets is really important in order for money to flow to priorities. Otherwise, they just tend to go to existing buildings, right? And if you just take last year's allocations and add on X% for inflation, you'll reinforce any, let's say, misallocations that are going on currently. So again, that's another piece of analysis which you really need to look at. And so there's a big agenda on budget formulation to start to shift the way budgets are formulated to reflect health priorities. Execution is a big one. And, you know, I mean, finance, I don't know if there's any Ministry of Finance representatives in the room. You know, they often look at health and go, you know, why should we give you more money when you're not spending the money you've got now? But what we now know from a lot of analysis is actually often, it's not the only reason, but often a major reason for low execution in health is late release of funds, right, by Ministry of Finance, and there's a host of other things again. But it's a fair point, right? Why put more money into a budget when it's not being spent? But, you know, it's more complicated than, it's a two-way thing there. And again, I think on the expenditure reporting, budget reporting, again, reflecting performance, right? So what did we achieve for the money? Not just did we spend it, but what did we achieve? And I think that's sort of, there's a big agenda there. And whether you've got insurance or not, I think it's incumbent on us to really start to tackle this agenda on really improving the way budgets are spent.
Thank you very much. What did we achieve for the money that was given to us? Great point. And so that brings me back to the issue, Owen, you made. That's the issue of efficiency. And again, I would want to be looking at that both from demand and supply side. If you look at whether it's tax-based or whether it's insurance, there are a lot of inefficiencies in terms of the way we even purchase. And so, Nathan, I'm coming back to you in terms of what you think we should be looking at if we need to be getting closer to UHC. What are the sort of things that we need to do to be a lot more efficient with respect to the way we spend our dollars on health in order to be able to get more health for the dollars available? So I would want you to focus primarily on the demand side, and I would move later on to the supply side. Thank you.
Thanks so much, Prof. But just by show of hand, is there anybody from any Ministry of Finance in Africa? Can you show me by hand? So actually, the lack of show of hands actually shows that when it comes to the conversation on health financing, ministries of finance come as guests to the table and not as partners. And this is something we have to reverse. And what I do know from ministries of finance is that they are looking at the entire economy. And I remember once sitting in front of a finance minister to say, look, we are not receiving the funds that are allocated to us. He says, I run a whole economy, I don't run health insurance. But having said that, what we need to show is how well we are using those finances that have been allocated to us. And I probably will look at it from 4 dimensions. They've been mentioned all a lot, you know, during this conversation, but I want to structure it a lot more formally. First of all, what package of services do we want to purchase for the population? So I'm talking basically about how do we purchase strategically. Our funding is not adequate for everything that we want. And this is, you know, the lesson 101 of economics, that we have scarce resources. So what do we allocate those resources to? Should be the priority services that as a country we think we should be paying attention to. And I think subsequently Edwin will talk about that. So what are the priority services? There are many tools for doing this. WHO has tools, there's HTA and so on. So it's basically an exercise in priority setting. Number 2, if we have limited funds and we want to purchase priority services, whom are we purchasing these services from? Are they healthcare providers that are able to provide quality services to our population or to our target populations? How do we determine the capacity of the facilities to provide those services in a quality, quality way that we all want to look at? So a lot of things also go into this. We look at accreditation, we look at credentialing in some countries, but there are many ways of actually identifying and selecting these providers and subsequently contracting with them. How do we contract with these facilities? Do we just have open-ended contracts? Do we have contracts that are asking them to provide a specific quality, of service that we are going to pay for? What are we paying for? The third is really, what payment mechanisms are we going to use? Are they payment mechanisms that are going to incentivize the provision of quality health services? And over here, the repertoire of mechanisms are replete with a lot of examples of what our countries have used. Ghana, we tried capitation. It got, curtailed at a point in time. I love one saying about capitation, which was on radio some time back, and I think most Ghanaians know it. But there was somebody who appeared on radio, and I think, Prof, you know that. The person said, I've heard about capitation. I don't like it, so I don't understand it. But every payment mechanism is legitimate, and they should be combined in the best way possible to achieve the outcomes that we want. And what is the optimal combination that we want is the question that we have to look at. And lastly, how do we monitor? And the monitoring really comes in many forms. We set out to purchase services. Are they being delivered to the standard that we required in the contract? Finally, we talked about information systems. We talk about how IT is continuing to play a very significant role in ensuring that we get the data that we require. I think the NHIA is doing a lot today. I've seen some of the quality data that has come out. But are we using it to the best ability possible is the question that we should be asking ourselves. Let me just stop here.
All right, thank you very much. I think that I'm going to move on, but there is also another important thing that you forgot, and that's the reason why I don't like it sitting here. I wish I were there. If I were sitting there, I probably would say you also need to focus on your mandate and stop wandering around and getting into things that is none of your business. Anyway, so let's move on. I don't know, Owen, if you want to say anything about demand side efficiency before we come to the supply side, because I think that from the supply side, oftentimes we look at the funding agencies, whether it's National Health Insurance or the Ministry of Finance. But we also know that there are a lot of inefficiencies in the production centers, okay? And we cannot just talk about the demand side without talking about the supply side. So because in actual fact, sometimes they are worse. So I would want you to talk about the demand side, if you have anything to add to that. And then we can, from there, get to Prof. Irene. She used to be at the supply side, so she can also tell us what we need to do. So, Owen.
Thank you. I think Nathan covered the demand side very well. And I think maybe just to be brief on the supply side, I mean, as I mentioned, certainly primary health care, I mean, allocating money to the level of primary health care instead of to hospital level is, probably the first sort of issue to deal with in terms of ensuring efficiency from the supply side. We know that there are a lot of health systems where 50, 60, 70% of the budget is going into hospitals, whether it's district hospitals or going up to tertiary hospitals, and this is just not the most efficient sort of use of resources. I think I'd mentioned earlier this World Health Organization report on, the World Health Report of 2010, which sort of launched a lot of the dialogue on UHC, and it has this list of top 10 issues for inefficiencies. And one of them was, I can't remember how they put it, but it was basically fraud, waste, and abuse, or corruption as a sort of a broader set. And certainly that's sort of a supply side issue. One could even say that absenteeism of health workers could be framed as a sort of inefficiency on the supply side. I would go even further than just saying primary health care. We know that community health workers, for example, who are working out in the communities, it's a very efficient utilization of resources. Often they're not paid salaries. They should be paid salaries, so that's a whole issue of its own. But generally speaking, paying for CHW, supporting community health beyond just a sort of a focus on brick and mortar facilities is an important sort of supply side aspect of improving efficiency. I'd mentioned procurement issues earlier, and also budget execution has been covered. I think all of these could be clubbed together as important supply side issues. But I defer to Professor Irene, who I think knows much more on this.
All right.
Thank you. You asked me to talk about supply issues, but I will avoid the supply-demand thing and kind of talk, it still comes in. Because you see, you were talking about efficiencies, and I want to take you back to the issue of fragmentation and synergies. And I'm going to use a real example, which is very topical now. Health insurance should cover renal dialysis. Universal health coverage, let me stay away from the controversial term health insurance, should cover renal dialysis. Now, actually, fundamental to universal health coverage is protection against catastrophic expenditure. And if you have to face renal dialysis, that's catastrophic expenditure. In all the conversation, and I've been listening to the news radio conversations and all the statements, I hardly hear anybody talking about the issue. Why do we have so much renal disease in this country? At the bottom of many of the renal failures that need dialysis is long-standing, poorly treated hypertension, diabetes, and in some cases, some of the bitters and other herbal medicines we are so fond of. Now, any conversation about this issue of renal dialysis, if you are thinking systems and you are thinking efficiency and you are thinking the issue of synergies I raised, I would expect to hear the conversation also talking about these things. And you may not have enough money in the national health insurance, but that's the other thing. Our whole health system is fragmented. The resources for health promotion are not part of national health insurance. It doesn't matter, but if you are handling the national health insurance, you need to learn to think the system and talk across the system and work with the system. Because when the system is working, it can reduce your costs. But, because a lot of the conversation I hear about reducing costs is, dealing with fraud and claims. It's all in order, but that's not all there is to it. So I would suggest that we need to start thinking a bit more holistically about the health system as a whole. And it's our comfort zone to be in our silos. I'm in charge of the National Health Insurance. I'm in charge of the Ghana Health Service. I'm in charge of CHAG. I'm in charge of training. Somebody has to do that thinking across the whole. Somebody has to be identifying the synergies which can bring in the efficiencies. And my other concern then, maybe it will come up later because I think we are going to talk about equity. So perhaps I'll pause here a bit and again push you back. And that's why I started off with that conceptual issue about the intersection between the agendas and synergies. When we get to equity, I'll make a few more comments.
All right,
Thank you.
good one, Des. Okay, all right.
I just want to really just add a point to what Irene said. I think this is really important, and I just very quickly, NHS is asking itself the question, or it's faced with this question: should it cover dialysis, right? And I mean, some of the conversations is that the cost could be so much, it's going to be a serious problem. The question is not just for NHS, right? And I think that's what Irene is saying. The question is for the health system. Right? And it's not just about it's just about giving dialysis, it's about managing diabetes, right? And so the solution to the question is not so much, is it sustainable for NHS to cover dialysis? It's can the health system as a whole sort of deal with diabetes? And it comes back to what Owen was saying, that primary level. I just wanted to make that point. And so you can't just address and tackle these questions from one bit of the health system. It has to be that system level perspective.
Fantastic. So basically, I think that this will be our last one, and we would be done. So I think that Prof. Irene talked about somebody is got to be responsible to put everybody together. So that's leadership. Again, there is another elephant sitting by the side. That's NCDs. Okay. Again, I'm not referring to your elephant. I'm referring to the elephant over there. So that's NCDs, and that's a waiting bomb. How do we look at allocating resources in such a way that we'll be able to deal with the issue of NCD. And I believe that that's also equity, because at the moment we seem to be just thinking about about communicable diseases. But non-communicable diseases are also staring at us. And if we don't look at that, it's also equity. Equity is not just about the income gradient. This is also equity. How do we address that issue? And I'll come to you, Ed.
Mr. Moderator, I think that should be in your closing. Let's get back to the audience, let them make their submissions, and then in closing, you can put that in perspective.
All right. Okay.
So we shall take 5 interventions, and then we shall revert to the panel for closing. Let's start with you at the back, Honorable.
Okay, thank you very much. I've had quite a bit. There's something missing in the African story. Elsewhere, people bequeath a lot to healthcare. They bequeath at their death. And that is huge. Huge. Our culture, honestly, if you even beg somebody to help you put up a ward, it's difficult. So in the European or Western world, in as much as you're getting financing through all the various things, that bit where people bequeath to healthcare is missing entirely. I don't know about our Francophone countries, but here in Ghana, I haven't heard of one powerful rich man bequeath a lot at his death to any health facility. If you've heard, please tell me. So that is an additional thing we should look at. I don't know how, maybe one future late president might do that right, but I don't know.
Thank you.
So it's an additional financing they get that we don't get.
Okay.
Maybe Emerson.
The rich people pay for hospital bills on their birthdays. That I know. Let's go to the back. Yes. Sure.
Merci. J'ai suivi ce débat, il est très intéressant, mais il y a 2 points qui ont été abordés par le professeur.
Indeed tackled by the professor. And that is the fight against fraud, which is a non-negligible means to increase the resources. If all the resources that we are being given are not sufficient, but that's a great part or greater part that is used in the fraud, then we are losing in terms of resources for this insurance. My question is, are there any countries that have had this experience of the weight of a fraudulent expenditure on health insurance? That is an important issue, a crucial issue where we can measure the impact of this fraudulent expenditure on health insurance. The second issue is linked to the delays in reimbursements from the Ministry of Finance on resources to the NHIS. I had a discussion with the Ministry of Finance. That's another priority, is paying the salaries of public officers and then paying the military expenditure and the rest that are also equally very important. But it seems to me that we are not advancing the good arguments. What are the health consequences of delayed payments from resources into the fund? And that is translated into how many months, for instance. Because these are the arguments that we have to really lead or discuss with. And so if we provide our resources with our 2 or 3 months of delays, this is the impact. If that has no impact and that you are giving resources in June or in July or in December for the Ministry of Finance, that will not change. And so it seems to me that we have to push the analysis to show them the consequences of the delays in payments for the resources for health institutions and for the state of health. This is the contribution I want to make here. Thank you.
Thank you so much to the panelists. Yeah, I just wanted to come in on the issue that was raised regarding the engagement with ministers of finance. It's quite important, and it's sad that when we have such gatherings and meetings whereby we go deeper, when we dive into health issues, ministers of finance are not here. From my own experience from Malawi, I make sure that when I'm preparing for such meetings with Minister of Finance, I should have all my guns ready with ammunition. And that is the data. I recall when we met the Principal Secretary for the Minister of Finance, actually, after just showing the data, he was the one busy suggesting solutions to us. We can do this, we can do this, we can go into earmark taxes. So I think what we need to do as people in the sector, we are the ones close to the communities, we are the ones experiencing the pain, but also we are the ones talking to our partners. I recall there was a meeting in Joburg whereby PEPFAR made an announcement that come 2030 there may not be any resources for health, for HIV/AIDS, but there was no Minister of Finance. It was us in that meeting. So it's important that when we are meeting the Ministers of Finance, we should give them all the data and all the information. At this point, the Ministers of Finance should know that come 2030, most of the money that's coming in from the external sources may not be there. So let's make sure that when we have those meetings, let's not just dress well, let's have our ammunitions, let's meet them at gunpoint. I'm telling you, our stories will change. Thank you.
We shall take one from you and finally from Madam.
Okay, thank you very much. Thank you, the panelists. So maybe my question is just short. I know from the presentation that we had yesterday and the discussion we have had today, on where we had the presentation of the recommended maybe average maybe cost per capita, if I'm not mistaken, around $86. That was maybe recommendable, but there are some countries that have done well with the amount below that, and then there are some who have been spending more. Maybe I was just wondering now, do we have maybe a recommended transmission mechanism costs? Because I've been talking maybe of the countries that have had maybe 2 or 3 national insurance system. Countries that have had hybrid system, maybe compulsory and maybe the one that is obligatory. So I was just wondering, maybe is there the amount that we have already started to see, how much actually that transmission mechanism costs maybe of pulling together the resources, or maybe whichever the approaches that are being recommended, costs apart from the actual cost that we have in delivering the service to the users or to the patients or to the consumers. Thank you very much.
Thank you very much. And the final one from the FCDO.
Thank you very much. I've enjoyed the frank discussions, and especially the facilitator who is itching to be on the other side. Some very good takeaways. Health is good politics, and maybe we need to play that better. Focus on the goal and the objectives and not the means. Really good. And lots of elephants. Luckily, we don't have too many here, but maybe we need to search for the elephants. But I wanted to focus on, as a donor, as you know, UK is a bilateral donor in Ghana, as well as a player on the global stage. So my question to you all is, how can we, as global development partners, do better to help Ghana and other lower middle income countries achieve UHC? I know it's a very broad one, but where we are now, what do you suggest we focus on to shift that dial and get better results in in lower middle income countries. Thank you.
Mr. Chairman, because we have the biggest elephant in the room, which is the consumer, it's important that we hear from the Consumer Protection Agency.
Yes, I'm a butterfly now. Dr. Kisi, who is also a politician. I think one of the major problems with Africa is we the people, we don't make healthcare as one of the elections issues in Africa. I've enjoyed NHIS in UK. I've enjoyed Medicare in the United States. It is a major campaign thing for any candidate. But in Ghana, which of the candidates is talking about healthcare? Nobody. Okay, so until we the people, who are the consumers, and I'm sure the gentleman, Mrs. Matthew, and Mr. Owen, you know that is a major issue in your countries where healthcare becomes one of the pillars when it comes to elections. So maybe we Africans, we should also look at how we are going to push it comes election time. Thank you.
All right. So, moderator, we've added 15 more minutes to your time so you can exhaust all of the questions.
All right, thank you for being generous. The good thing is that you've given us the opportunity to go back to the issue of equity. So, because from what I see here, lots of them are contributions. Only a few questions. I think generosity, I think it's about contribution. How do we combat fraudulent expenditure and then delays in reimbursement? So these two, I think we can put it together, and any of you who want to answer that can take a go at it.
So fraudulent expenditures, from my point of view, might be claims. That's how I understood it. We've seen some of them, but a lot of it is really kind of allegations, right? So what we have to do is to actually put the facts to those fraudulent allegations. But the question then becomes, what is the driver of some of those behaviors? Some of the drivers are the desire of healthcare providers, some of them, not all, a few, to behave rationally as economic beings. If I've not been paid my money in full at the time that I desire and want it, then I'm kind of motivated sometimes to behave, deal in some of these behaviors. Yesterday, and to another point, we were having a discussion and somebody said, look, there is a lot of extortion of monies at the healthcare provider level from patients. And some of those monies, I think one of the NHIS staff was saying is unauthorized. But nevertheless, the technology that we have can deal with some of those issues. And so I remember, I think in Korle Bu when they started, with bank collections, I think revenue started going high. And then you get to a position where now you have mobile money. Why are you not letting any kind of payment at the health facility be paid by mobile money to an official account? In that case, we can have a very good conversation about what is an unauthorized expense or payment and what is not. So talking about fraud, obviously we know that if you look at most systems around the world, it accounts for up to about 10% of losses. In the US, it's in the billions of dollars. And in Ghana, our expectation and thinking is that it might be hovering around 14%. So how do we find it? How do we deal with it? Is something that we should occupy ourselves with.
All right, thank you very much. Initially, I thought that you were going to say, bring me evidence.
Oh, by the way, the last thing is, we always assume that fraud is only by the healthcare provider. But we always assume it's at the healthcare provider's level. But it might be white wider than that. It could be a whole network that does not only include healthcare providers. So let's look a lot more broadly when we talk about fraud.
All right, thank you very much. Once you are not asking me, bring evidence, at least I'm fine with you. So, Edwin, would you want to talk about, there's a question about what do we do about delays in Ministry of Finance reimbursing? There's a question on that.
Thanks, Gordon. I think there was a specific example of the NHIS, but this is something that affects pretty much every other health system. The issue of delays in disbursement can be approached in many ways, but it boils down to PFM efficiencies. It's really about looking at the entire PFM process, identifying the bottlenecks around formulation, identifying bottlenecks around execution that will then allow funds to flow. So it's bottlenecks along the entire chain. So it's really about diagnosing those bottlenecks and addressing them. To give a very simple example, when you think about subnational level and facility level autonomy as an aspect of funding flows, when you have systems that either do not have autonomy at the subnational level or autonomy at the health facility level, or require a lot of processes for funds to be released, then you end up with delays. But once you provide autonomy at those very local levels, then it unlocks some of those delays.
All right. Okay. Thank you very much. So I think there was a question here, but I don't seem to get that question very well. The person was asking as cost of delivery. I don't know whether you get it.
Yeah, so if I got that correctly, I think what the question was around was administration costs. So we keep on talking about the costs that go into service delivery, but there is a cost of doing business, or the transaction cost. And the answer to your question is there is no gold standard. I've searched for it myself. There is no gold standard for administration costs for agencies like the NHIS and so on. But there's an analysis that was done many years ago, I think it's now 10 or 15 years, that found that for such agencies on average, admin costs are 5%. So it varies, but admin costs are 5%. But countries behave differently. In Kenya, for instance, the NHIF at some point had 50% admin costs, which was considered hopelessly inefficient. And we've gone through a process of reducing it. And now we have a bill in Parliament that wants to legislate 5% as a cap. So it's really about trying to drive admin costs down so that you improve efficiencies. You spend your money on what matters most, which is delivery of services.
Okay, maybe we should also legislate in Ghana that 5% is the cap and don't go beyond that. All right, and I think the last question is about what should we do as donors to help Ghana and by extension all the other countries in Africa to be able to achieve UHC? That's a hippo question, right? This one is not an elephant. Okay, so Matt, would you want to try it?
Yeah, just a couple of quick reflections on the other questions first. The fraudulent behavior, I think the use of IT, e-claims is clearly a huge, not just for efficiency, but for dealing with corruption. I think there's a huge potential benefit, and that's coming, and it's quite low cost. Just the other thing to mention on fraudulent behavior, especially in claims, right? Provider payment system. Basic economics, think about incentives. When you basically pay providers through claims, and this happens in all countries in the world, you will get some fraudulent claims, right? It's going to happen. Now, what some countries have done is you switch away from that reimbursement mechanism to some kind of a fixed annual budget, right? And there's ways of working out a fixed annual budget to hospitals. And just, you don't solve all the problems, but in a way, you completely remove that incentive for fraudulent claims. There are other problems which will arise, but I think thinking about the incentives that come with the provider payment can actually help to tackle that as well. Just on the late salaries, if I hadn't been paid for the last 3 months, I'd feel pretty demotivated, right? And if I was a low-paid worker, and let's not forget, the reliance we had on health workers during the pandemic, right? That I might also ask for someone to help contribute, right, so I can buy food and so on. So I think that just needs saying. On the, the role of international, I think maybe colleagues will have more to say. I mean, just one thing to point there. I think the bilaterals in particular have a responsibility with some of the new global health initiatives. There's a lot of discussion on this going on at the moment, and this concern about parallel systems having been built up on the back of heavily externally funded disease programs. And I still think of, we were talking yesterday about how the title of papers sticks in your mind, right? And there's one, I think it's about 15 years ago even, from Kenya, and the title is In the Shadowlands of the Global Health Programs. This sense that some of these big vertical programs, very dependent on external donors, they can sort of dominate health systems. They can actually weaken other parts of the health system by sucking in labor and other resources. And it's not just to criticize. I mean, everyone is doing this with the best intentions, right? And don't want that to be taken wrong. But I mean, the bilats fund these agencies. Well, not entirely, but so I think that's one big issue that's currently on the agenda. So.
All right, thank you very much. So I've been noted that I have 5 minutes, and for equity reasons, we'll go to equity. So I asked a question about how do we ensure that we better allocate resources in a manner that is equitable. And so we were looking at the issue of communicable and non-communicable diseases. I'll start with you, Prof. Irene, and then I'll move to Owen.
Thank you. The first thing I'll say is that if you want equity in UHC, you must be universal. You can't run away from that. If you are not universal, you don't have equity. And there are layers of the inequity. Let me use Ghana as an example. We have about 50 optimistic scenarios, 60% NHIS coverage. We've done very well. It's an incredible achievement. It's inequitable. And there are layers of the inequity, because what happens is that if I renew my insurance, I have access, and the Ghana scheme is tax funded, which is to the credit of Ghana, and we shouldn't change that. It's over 90% tax funded. It's pooled. That's wonderful. But what it means is that the 50% who are insured are the ones consuming the 90% of the tax funding. The remaining 50% who are not insured have contributed to the tax funding. They are not consuming any of it. That's a huge inequity. I could go on and on with examples, but I want to make my point very, very strongly that if you want UHC, you cannot run away from equity. It's a hard challenge. It's a dilemma. It's difficult, but you need to keep pushing against that envelope. And the other thing is that I know it's difficult, but there are costs to targeting. I think years ago, one of the PhD students I co-supervised did a paper where they assessed the cost of targeting. As the numbers of poor, there's a cost to finding a poor person, whether you do it via LEAP or via whatever. As the poverty incidence rises, the number of people who live below the poverty line, it gets more and more expensive to target. It's better just to be universal and allow the rich and the poor in together. The other thing you do is that you create two worlds. The world, and even the poor don't want to be in the world of the poor. I can give an example from, yes, because it's stigmatized. You know, that's the health center for the poor people who can't pay anything else. Who wants to have that label, a poor person who can't pay anything else? So even they run away into the private clinics. So I want to make a strong appeal that hard as it is, we need to sit down and find how to make the Ghana National and all the national health insurance schemes you are thinking of universal. If you don't start the thinking, you are not going to get there. And the last quick point I'll make, I know you are running short of time. There's a book, I think, I keep sending people who do the policy course to go and read. It's by Professor Aye in the University of Ghana, Department of Political Science, called Saints, Wizards, Demons, and Systems. The reality is that any major reform is political as well as technical. You need the politicians and you need the technical people. You cannot push through major reform without these two groups. The problem is that we like our comfort zones. So what happens is that the technical people are uncomfortable with the politics, and the political people are uncomfortable with the technical people, because I'm telling you that a technical person doing their work well may disagree with you as a politician. And a politician doing their work well may think the technical person is, pie in the sky. This is going to lose me an election, and so on and so forth. So again, I'll send you, go read Professor Ai's book. We don't have time today, we can discuss it, but I'll make a strong appeal. When he talks about wizards, he says that the technocrats are inappropriate, and it's part of our challenge now. It's not that the answers are not there, but sometimes you are not getting all the people who can think through the issue round the table, and it comes back to the conflict between the politics and the technical things. And I'm known for saying what should not be said, so forgive me. Thank you.
Thank you very much. So Owen, I think you can make your point, and then we should be about rounding up.
Thank you. I mean, I agree with Professor Irene about this equity story. We should be clear that if there is targeting, that this is a temporary solution, that the destination really has to be universality. If you think about the cost of a hospitalization, that is going to be catastrophic for the vast majority of households in most of the countries that we're talking about. Even if they're, the 80th or 90th percentile of the population, if they have a very expensive hospitalization, it can be catastrophic and impoverishing. So we can't be satisfied that we're covering 55% or 30% or whatever. It has to go much higher, and the sooner the better. Now, countries do have, for their social protection programs, like LEAP in Ghana, in other countries, these social registries which are being developed. I think generally speaking, they're helpful for targeting. They're not perfect, but they're usually doing better than if you're just doing community-based targeting. But I mean, going back to what we were saying earlier, primary health care is going to be more equitable. Capitation can be a fairly useful way of better distributing resources across the population. I think that some countries have resource allocation formulas, so they look at the regional level and try to allocate money based on health needs and poverty incidence within specific regions. Otherwise, you find budgets end up being captured in the capital cities and in the larger cities, and they don't reach to other parts of the country. Final point, I just want to go back to the politics. I think there's evidence from many countries, well, let's not say many, but a number of countries in very different time periods, that the stronger political voice of women leads to stronger health systems and stronger health spending. To give concrete examples, at the village level in India, when the village chief was a woman, they spent more on health projects than on other projects. When the United States gave women the right to vote about 110 years ago, there was a sudden jump in health spending, particularly on child health services. So politicians realized that this was a good way to win votes of women. I saw a study in India just 3 days ago where they looked at the questions that were asked in Parliament by female members of Parliament and male members of Parliament, and the women were asking way more questions on health and education than the men MPs were. So I think if we can improve the political voice of women, whether it's in voting, whether it's in Parliament, that can also support health systems.
Thank you very much. So what we are hearing is that universality and gendered approach to financing. Maybe we should make, we should put the women in all those places. So on that note, ladies and gentlemen, thank you very much. And I think it would be good to have a round of applause for these smart people. Thank you so much.
And for the man who has done a good job by steering the affairs of these smart men and women, Professor Gordon Abekan Nkrumah. Ladies and gentlemen, a round of applause. Somebody sent me a little message concerning what they've been talking about. It says we treat healthcare as a commodity and not as a right, which has led to poor social responsibility and fiscal irresponsibility, very far away from its roots as a social service. It means we must make more and smarter investments in the foundations of health systems with an emphasis on primary health care, essential services, and marginalized populations. Well, some may agree, some won't, but that is why we take the discussion on funding universal health coverage many notches higher through 3 breakout sessions. Can we have a display of the various breakout sessions? So in room 1, which is Damba, outside, yours is improving service coverage and access to services, especially equity. For those who remain here, this is room 2. Yours will be removing financial barriers. And then room 3, which is the Kundum, it will be ensuring efficient spending for sustainable health financing systems. What we're going to do in the breakout session is as follows. We're going to have a facilitator, a co-facilitator, who comes from an academic wing. We're going to have a technical note taker and then discussants. After your session, we will all reconvene here where the 3 facilitators will present their paper, and I believe at the end of it, we shall call it a day and proceed to lunch. Ladies and gentlemen, talking about what we at the NHIS are doing by making sure that we advance the course of our 5 Ds, which are digitization, I beg your pardon, dissemination, development, decentralization, and data. We want to make data central to all the decisions we undertake. And that's why, ladies and gentlemen, when you go outside on coffee break, you're going to see a display of data which will speak to so many things. You're going to witness our share of antibiotic prescriptions by age band and gender. You're also going to see the top 10 prescribed antibiotics by cost, yearly utilization funds by age groups, and you're going to see yearly cost trend by age groups. Please don't miss that for anything. I think, oh, okay, I thought they were showing it on the screen. But please, when you just move outside where the coffee and tea is served, you will see all of this data. Acquaint yourselves, and you'll be happy you did. So right now, bon appetit. We shall move to our respective breakout sessions and reconvene here in exactly 1 hour. It's coffee and break. 10 minutes for coffee and tea, and then we go.